Hello, and welcome to this evening's webinar, Free to Breathe, Understanding Lung Cancer Prevention, Detection, and Treatment. Thank you for prioritizing your health this evening. I'm Stephanie Nichols, Marketing Director for Oncology here at Franciscan Health. I'm excited that you are joining us for this installment of our Health Education webinar series. This evening, we'll better understand types of lung cancer and lung cancer syndromes, risk factors, symptoms, early detection and $49 lung scans, and lung cancer survivorship. Let me address some housekeeping items before I introduce our presenters. We'll start with a quick tour of the GoToWebinar attendee interface. The audio is a section that controls how you hear the session. We have a lot of content to get through, so all of our attendees are in listen-only mode. We have some great resources for you in the handout section, so make sure you download those items before the session ends. And we'll be answering your questions at the end of the webinar, so we have enabled our questions feature. If you have any questions, feel free to type them in the question box. Our awesome administrators, Ben and Kirsten, are taking care of everything on the back end. So if you have any issues during our session, just type your issue into the question box. And if you miss anything, don't worry. We will send out the on-demand recording when it's available. So Franciscan Health is home to some of the country's most well-respected physicians and clinical specialists. It is truly my honor to introduce you to the experts who will present our session this evening. This evening you will hear from Dr. Nanya Mangar. She is a medical oncologist and hematologist with Franciscan Physician Network and recently started in the Franciscan Health Woodland Cancer Care Center in Michigan City. She received her medical degree from IU School of Medicine and did a residency and fellowship in medical oncology and hematology at the University of Illinois at Chicago. Dr. Mangar's philosophy of care is to provide the same level of care that she would provide to her own mom and dad, because her patients are someone else's mom and dad. Her clinical interests are survivorship cancer care, smoking cessation, clinical research, hematology malignancies, and care for veterans. She is most passionate about patient care and encourages open communication with her patients. Dr. Mangar is newly married, loves working out, reading, and cooking. You will also hear from Dr. Gregory Hinkle, radiologist at Franciscan Health Olympia Fields in Illinois, on the importance of early detection of lung cancer and how $49 could save your life. And finally, we will learn about advanced treatment options and survivorship for lung cancer patients from Dr. Nadim Iqlaq, who specializes in lung cancer and is a medical oncologist with Franciscan Physician Network in Indianapolis and Mooresville. Dr. Iqlaq was also recognized as one of the top doctors from the 2018-2019 Indianapolis Monthly for Hematology Medical Oncology. We'd like to understand a little bit about our audience before we get started. Let's start with a quick poll question. Why are you attending the lung cancer seminar this evening? Please go ahead and select one. Okay, see a few of you still voting. All right. Well, it looks like the majority of you are here because you want to learn more about your risk, and we have a few smokers who want to know their risk. So it sounds like risk is the common theme for our attendees. Without further ado, please welcome Dr. Mangar as she explains the types of lung cancer and lung cancer syndromes.
Hi, everyone. It is such an honor to be here to talk with you all. One of my passions is education in the community and talking more about cancer and risk factors, especially for lung cancer. It's something that's so important to talk about as 40% of Hoosiers smoke cigarettes. So it is something that it's a public health issue that I think it's important we all talk about. So let's go ahead and move forward and talk about the incidence of lung cancer. So here we have kind of a diagram of estimated new cases and estimated deaths of cancer across the United States. So if you look at the top graph, we look at estimated new cases, you can see that lung cancer is the second most common type of cancer in men and women, accounting for about 150,000 new cases 250,000 new cases a year. More common for men is prostate cancer, and more common for women is breast cancer. If you move lower down to the estimated death graph, you can see that, unfortunately, lung cancer is the #1 cause of cancer death in both men and women. It accounts for about 135,000 deaths per year, and that is more deaths than prostate cancer, colon cancer, and breast cancer combined. So it really is a public health issue and something that in the medical community we're working towards decreasing. So this is a very busy slide, but I'll kind of just walk you through some of the points. If we look across on the left-hand side, you can see 5-year survival. So this is looking at many different types of cancers and what the 5-year survival is for patients that get early, middle, or advanced stage cancers. If you move 3 rows over and 1 column down, you can see lung and bronchus cancer. Now, what this graph is basically showing us is that patients that get local lung cancer have a 5-year survival about 60%. This drops if you have locally advanced disease or regional disease, we call it, to about 30% at 5 years. And unfortunately, if someone presents with distant or stage 4 lung cancer, their 5-year survival is about 5%. This is one of the reasons that lung cancer is one of the most common causes of death in our cancer patients, because we don't have great treatments at this time for distant disease. Now let's move over to the right-hand side where you can look at stage at diagnosis. So this is looking at what stage is someone when they're diagnosed with cancer. Again, we can see the lung and bronchus cancer, and you see that not many patients are found to have early cancers, meaning localized or regional disease. That accounts for less than half of our patients. Unfortunately, anywhere from 50 to 60% of patients present with stage 4 or advanced disease, and those are the patients who have a poor survival at 5 years of less than 5%. So this is wherein lies the problem, is that we are diagnosing a lot of people too late, and at that point, we don't have optimal treatment options, and this is really where early detection and minimizing risk comes into hand. Now, I wanted to talk about our trends in mortality in lung cancer because it is something that's really important in the world of medical oncology. So on the left side, you can see that there is a decrease in incidence of lung cancer, and so this is how many new cases that we have a year. Now, if you look at this graph, this really started to decrease in the 1990s, and we'll talk about why that is. And on the right-hand side, we also see that slowly over time, there is an increased survival in patients who have lung cancer. Now, again, as we talked about, the 5-year survival for patients with stage 4 lung cancer is still low, but we are working towards early detection and new treatment options. Now, if you look over to the right, you can see various types of cancers for men and women, and you can see the deaths per 100,000 people in the community. The red lines are lung cancer. So you can see that while the mortality rate for lung cancer is going down, it is still the #1 killer of both men and women in the United States. So their incidence is going down and the death rates are going down, but we still have a ways to go. So let's first talk about the types of lung cancer. So there is non-small cell lung cancer and small cell lung cancer. So first, let's talk about small cell lung cancer. That's on the left-hand side. So this is a less common type of lung cancer. It's about in 15% of patients. The reason the cells are small is basically because it's a very aggressive cancer, and these cells multiply very quickly. So they stay small and multiply over and over in a rapid amount of time. There are some studies that the time a tumor that is small cell lung cancer can double can be anywhere from 4 to 8 days. So meaning that if you have a 2-centimeter cancer, anywhere in a week or two, it could grow to a 4-centimeter cancer. So because this is such an aggressive cancer, most of the time we see very aggressive symptoms. So we see rapid weight loss, 20, 30 pounds over a month or two, severe shortness of breath, and oftentimes patients will cough up blood. This cancer is almost exclusively in patients who smoke. So about 99% of small cell lung cancers occur in patients who are smokers. If we move over to the right side, we talked about non-small cell lung cancer. So this is the majority of lung cancers. So these are all other histologies of lung cancer. It's about 85% of patients here on the right side. So the types of histologies are called adenocarcinoma, squamous carcinoma, large cell, and not otherwise specified, meaning they can't determine exactly what the makeup is. These are just when we look under a microscope at the biopsy of the type of cancer, what the histology shows us. And these are all the different things under the umbrella of non-small cell cancer. Now, this cancer can develop slowly over time, and the symptoms aren't quite as quick as small cell lung cancer. The different signs we see here are shortness of breath, cough. Sometimes patients will present with recurrent infections in the lung, like pneumonia. Patients can cough up blood, and then we'll also see some weight loss in these patients. So let's go ahead and talk about the risk factors for lung cancer, because this is a place that we can intervene and be better. So without a doubt, the number one risk factor for lung cancer is smoking. So this is an ad from the early 1900s. I think it's from 1950, and it's basically for Luckies. And it basically says Luckies are less irritating. 20,679 physicians say that. And so really the cigarettes themselves were created in the 19th century and became really popular around wartime, and were very commonly used as a status symbol in the early 1900s. Really, we didn't have a lot of data on the side effects and the toxins in cigarettes. And so it really wasn't until the 1960s, 70s, 80s, we started to have more data that smoking is directly linked to lung cancer and other types of cancers. So this was a famous publication by the Surgeon General in the 1960s called Smoking and Health. And it was basically a report of an advisory committee showing that smoking was a public health crisis, causing an increase not only in lung cancer, but in other deaths. So in the 1970s, we started to see taxes in cigarette smoking. And as you can see in the red line, which is our sales of lung cancer, sales of cigarettes started to go down really in the 1990s. And at the same time, the price was going up. So this tax on cigarettes was beneficial to decrease the amount of consumers who were buying cigarettes. So what you could see is about in 1964, about 43%, almost half of Americans were smoking. And now, because of increases in prices and smoking and increased awareness about the different kinds of cancers and other problems smoking can cause, in 2012, it's about 18% of Americans who are smoking. Unfortunately, in Indiana, this number is still somewhere between 30 and 40%. But there is an estimation that probably somewhere between 8 to 10 million lives have been saved since the 1990s with taxes on cigarettes, with the decrease in deaths related to smoking and just decreased smoking in general. So not only is it important for us to talk about smoking and smoking cessation, because we do know that about 90% of lung cancers arise in patients who smoke, and it's pretty uncommon for non-smokers to develop lung cancer. Smoking increases someone's lifetime risk of lung cancer by anywhere from 40 to 50%, and it's estimated to have somewhere between a lifetime incidence for a patient who smokes, somewhere between 5 and 10%. The other issue I talked about earlier was late detection. So unfortunately, most patients we diagnose, they have advanced disease and we have limited treatment options. So this is where lung cancer screening comes in. For us to be able to screen patients when they have an early stage cancer, before they have symptoms even, and potentially save their life. So as we talked about, lung cancer is the number one cause of death. And about a decade ago, we started doing low-dose CT scans to detect lung cancer to save lives. So initially, there was some controversy about the level of radiation in these scans, but actually the level of radiation in these scans is so low that it's pretty similar to living a general life and living in the United States, just the radiation you get from being living in a developed nation. So we started screening patients that were high risk, and we found that we could actually save more lives with lung cancer screenings than we did with colonoscopies and mammograms combined. Now, the issue is only 1 in 8 adults who meets the criteria for screening actually does get screened for lung cancer. So it's really important that if you have a smoking history or you have a loved one who does, that you talk to your primary care doctor about a low-dose CT scan for detection for lung cancer. So who qualifies for a lung cancer screening? So it's not going to benefit everyone. The people that we found that it benefits to detect an early cancer and save their life are patients between the age of 55 and 80, those who have a heavy smoking history. So that is someone who smoked more than a pack a day for the last 30 years or around 30 years, or they've smoked 2 packs a day for 15 years, basically adding up to 30 pack years is what we call that. And someone who either smokes now or if they quit within the last 15 years. All of those people who meet all of those criteria are eligible for low-dose lung screening CTs. So those were just some of the overviews of lung cancer. Really, the take-home message is that the most important thing that any person can do to decrease the risk of lung cancer is to quit smoking. Actually, there was a study done that the number one thing all Americans can do to increase their lifespan is to quit smoking, even outside of lung cancer. The other take-home point is that lung cancer often presents very late, and because it presents late, we have limited treatment options, and often our patients pass away from the disease. We have found that in the right patients, if we do a lung screening CT, we are able to increase early detection and save those patients' lives. So ultimately, I think it's important that everyone work towards a plan to quit smoking. And if you are a smoker or you've quit in the last 15 years, congratulations. But it's also important that you get your annual CT scan so that if you do end up developing a lung cancer, we're able to detect it and treat it to cure you of the lung cancer. So that's everything I have right now. I'll turn it over to Stephanie.
Thank you, Dr. Mangar. What great information. Before we move on to the next section, let's do another quick poll question. Lung cancer is the #1 cause of cancer death, more than prostate, colon, and breast cancer combined. True or false? Okay, just a few more are voting. All right, we can go ahead and reveal. Yes, majority of you answered true, and that is true. Dr. Mangar said that is the #1 cause of cancer death, more than prostate, colon, and breast cancer combined. Dr. Mangar talked about the importance of early detection and the $49 lung scan, and so now we have a video to share with you from Dr. Hinkle on the lung CT scan. Okay, we're going to try that again. Thanks for your patience. We are trying one more thing to get this playing. Okay, let's go ahead and try the next video. You'll hear from Dr. Nadim Iklak, on our medical oncologist, on lung cancer and advanced treatment options. Okay, it looks like we're having some trouble with our video, so I truly apologize for that. We will go ahead and send these videos out in the emails following up the seminar so that you can watch them. And Dr. Mangar, being on the phone, our medical oncologist, she's going to talk about lung CT scans and just kind of your experience of what that would look like. And then also talk a little bit about some of the new advancements in cancer treatment for lung cancer. And then we'll open it up to our question and answer at the end.
All right, everyone. So again, the videos will be sent out if you have more questions about them, but I will kind of walk you through the basics of a lung screening CT. So if you're a primary care or other doctor says that you qualify for a CT, and again, we have screening CTs at Franciscan. Basically what happens is you get a low dose CT scan. So low dose meaning that there's a very low dose of radiation and your chest is basically scanned. So that is read by a radiologist or a specialist who looks at those imaging, and basically they'll see if they can see anything in the lung. Now, a lot of times, especially for patients who smoke, you can see some scar tissue in the lung. So not everything that is a lesion in the lung necessarily is a cancer. Depending on the size or scarring of what they see, they can either screen you every year because it's not something concerning. They may do another screen in 3 to 6 months to see if the lesion has or hasn't grown, or they may decide to go ahead and pursue biopsy or workup for potential lung cancer. Now, for a majority of patients, this is a screening, so we don't expect it to be positive. So a majority of patients will end up doing annual screenings, and if there is something flagged, they'll get called for how to work it up further. So that really is the basics of a low-dose CT scan. It's very accessible at Franciscan, and we really do recommend it for every patient between the ages of 55 and 80. And again, a screening CT in the right patient actually saves more lives and diagnoses early lung cancers and saves more people than colonoscopies and mammograms combined. So it is something that's really important. And the reason we talk about it is because only 1 in 8 patients who qualifies for it actually gets a screening CT. So it is a big public health measure that we're trying to improve so that we can detect cancers earlier and potentially cure our patients. I also wanted to talk a little bit more about the different advancements in lung cancer. Now, the field of lung cancer has really changed a lot over the last 10 years. So when I went to medical school and how I practice now has completely changed in terms of the stages of lung cancer. Now, most of our early stage lung cancers are usually treated with surgery, meaning removing part of the lobe of the lung that has the cancer. And then depending on a patient's risk, they sometimes can also get radiation and chemotherapy after surgery. We are seeing new advancements in immunotherapy. So for those of you who don't know what immunotherapy is, this is a new type of treatment that is used primarily in lung cancer to basically train your own immune system to fight a cancer if you were diagnosed with an advanced cancer. So immunotherapy, sometimes combined with chemotherapy or by itself, has really changed how we treat lung cancer. And we're actually seeing for our advanced stage patients who present with stage 4 disease, sometimes anywhere from 5 to 10% of patients who qualify for immunotherapy can have a very good response. And in rare patients, we can see a cure. Now, I don't use the word cure lightly because it's something that's kind of evolving in the world of lung cancer, but we are seeing a lot of new options for patients that even 5-10 years ago weren't available. The final frontier in lung cancer is really going to be targeted therapy. So what that means is that when someone is diagnosed with lung cancer, we look at their tissue, that cancer tissue, under a microscope, and we look at it at 400 times magnification. We also run it for very special stains to see what mutations that tumor has. And this is all kind of part of the theory of how do tumors arise and what makes them grow. So we actually run next-gen sequencing panels of 40 to 50 genes on individual lung cancer tumors. About anywhere from a third to half of patients can have a certain mutation, and those patients actually can benefit from oral pills rather than doing chemotherapy. So the future of lung cancer, and probably other cancers as well, is going to be targeted therapy, meaning looking at a cancer under a microscope, testing it for genes, and treating the specific gene that has an issue. So these are some of the exciting advancements in lung cancer, but ultimately the most important thing is that we can detect people early so that we can offer them a cure.
Thank you so much. Like I said, the video will have some more details that we'll share with you, but I'd like to open it up to some questions. We actually have had a few come through, and we can go ahead and start with those, and anybody else would like to put them in over on your question box. We'll get them, and then we'll read them off, and Dr. Mangar will respond. So the first question is, what is a PET scan?
So that's a great question. A PET scan we use in conjunction with a CT scan. So a PET scan is a special scan that looks at where a potential cancer could be. So what we do is we inject someone with sugar into their veins, like a sugar solution, and it actually goes to all the places that a potential cancer could be. So we inject the sugar, and then we look in a patient's body where things are lighting up. And by lighting up, it's usually on a scale of 0 to 20. So that's called an FUV, or the grade that something lights up. So anything less than 5 is generally not considered cancer. It can just be artifact or background noise, basically. Anything greater than 5 makes us think that, yes, this probably is part of the cancer. So a PET scan is more specific than a CT scan because it can actually show us that places we think active cancer is. We use this with a CT scan because CT scans aren't perfect. While they can look at the body, they can often miss a lot of lung cancer. So that's why we use a PET scan when staging many cancers, but primarily it's used in lung cancer.
Okay, great. Someone said, what about small lung nodules? So I guess what are the risks of having small lung nodules?
So that's a really great question. That is actually something that's very debated in the field of pulmonology and oncology. Small lung nodules really depend on the size. Most nodules that are less than 5 millimeters are less likely to be cancer. It's generally when a nodule is greater than a centimeter or it's growing, meaning that it's grown by 50% of its size within 3 to 6 months. Those are usually more concerning for a cancer. So not all nodules are the same. The other thing is that lung, just like, so if you look at your skin, everyone has, bruises or scars. So the inside of your body also has scars. So a lot of times nodules can just be old scar tissue in your lungs. So it not only depends on if you have a nodule, but also how long it's been there. So if someone has, a very small nodule, but it's been on chest x-rays for 5-6 years, it's much less likely to be something that's concerning. Generally, more concerning lung nodules are things that are greater than a centimeter or that are growing. And there's actually certain guidelines online called the Fleshner criteria that help us determine what the probability is of a nodule being cancerous or not. And based on that probability, we either recommend a biopsy because we think it could be a cancer. We recommend repeat 6 scans to kind of follow to see if anything changes with the nodule, or if it's been there for a long time, we don't recommend any further workup for it.
Great, thank you. Someone asked CT scans and radiation to patients. So I guess the question is, do CT scans give a lot of radiation exposure to patients?
So that is a great question, and the reason we do low dose CT scans is because it's actually a very negligible amount of radiation. Obviously everything we do has risks and benefits. We want to minimize risks and maximize benefits. So the reason we do low dose CT scans is because they have the lowest possible dose of radiation, but we're also still able to detect any early lung cancers in the lungs. There generally isn't much more radiation in a low dose CT scan than there is in just the environment of living in a developed nation. So that's why we haven't seen an increased risk of second cancers from low dose CT scans, but rather we've seen more early detections of patients who would have had a lung cancer otherwise that would have been later presented.
Thank you. Okay, these next questions are kind of all together in one. So how old do you have to be to get a lung scan? Do you have to get one every year? And does it require a physician order, a physician referral? So
generally, if patients over the age of 55 are when we start referring people for CT scans. They are recommended to be annual because the risk does go up every year that someone smokes. I would recommend that that you see your primary care doctor if you're planning to get one, because they can follow up on it. And I think Stephanie can maybe share more details about the $49 lung scans.
Yes, we will share a flyer that has all the criteria listed for age, smoke pack history, age, other risk factors, and so that will be shared with everyone in a follow-up email. Okay, some more questions. How long do most lung cancer treatments last? Do most lung cancer patients do chemo and radiation, or just one?
So this is a really great question too, and this is kind of where the staging of the lung cancer is so important. So for early stage lung cancers, generally we can offer a surgery to remove the cancer. If the cancer starts to get bigger or invading other things near the lungs, then sometimes surgery on its own isn't enough, and we have to do chemotherapy afterwards, and sometimes also radiation at times. This really depends on the size of the tumor and where it's located in the lung. So that's why we see such different treatment options for different patients, because it really does depend. Sometimes a cancer is more spread in the lungs, and it's not possible for us to operate on it and remove all of the cancer. So in that instance, we recommend chemotherapy and radiation. Generally, this lasts for anywhere from three months to a year. And then there are some patients that have advanced lung cancer or stage 4 disease, and we are not able to do surgery to offer them a cure. And so we generally give those patients either chemotherapy or immunotherapy or oral pills, or some combination of those. And generally, that is when patients are on treatment for the rest of their life in most cases. So it really does depend on the type of lung cancer, the stage, the size, where in the lung it's located, if our patient is healthy enough to undergo a surgery, and then what the tumor actually looks like, what the molecular targets are. So it's a complex answer, I know, but it's just because we really try to target therapy so that we don't overtreat some people, but also so that we don't undertreat other people.
Can you talk a little bit about genetics and the role genetics play in lung cancer?
Yes. So at this time, there aren't really a lot of genetic syndromes that we know that contribute to lung cancer. So generally, if we see lung cancer in families, it's more likely linked to smoking. There are some very rare genetic syndromes, but they're not very common. Most of the time, it is cigarette smoking that causes lung cancer. When we look at the genetics of a tumor, meaning what genes makes up the lung cancer, there are about 50 different genes that can be driving a lung cancer. There's really 3 or 4 that are pretty common, and we actually have a lot of oral pills to target these genes. But basically that is done when we do a biopsy and we run the cancer for a bunch of special stains, including multiple genes.
Thank you. If you have had a transplant, are you more at risk for lung cancer?
So that is a really good question. It doesn't look like lung transplants on their own increase the risk of lung cancer. If someone has a lung transplant and they start smoking, that can increase the risk. Some of the medicines you take to suppress your immune system when you have lung cancer can cause some other issues, but not necessarily lung cancers.
Okay, thank you. Why does Indiana have a higher rate of lung cancer?
So one of the reasons that Indiana's rates are so high is because we have one of the highest rates of smoking in the nation. So across the U.S., if you look at different states, the number of people who smoke really changes. So it's about 18% across the United States, but unfortunately in Indiana, about 4 in 10 Hoosiers is an active smoker. So because we have more patients who smoke, we end up having more patients with lung cancer.
Is there any correlation between vaping or marijuana or other recreational drug use and lung cancer?
So another really good question. the biggest risk for lung cancer in terms of other drugs is inhaling those drugs. So anything that you light and smoke, that is going to irritate your airways, including your throat, in your neck, and your lungs, and that is going to increase the risk of cancer. So someone who is smoking marijuana, that smoke itself, that inhalation can irritate the lungs and increase the risk. So in terms of things that aren't cigarettes, anything that we smoke is going to increase the risk of lung cancer.
So to that point, in the pandemic of COVID, what is the risk, or is there anything that patients who have lung cancer need to be aware of during the COVID pandemic?
So, it's such a strange year because it's just, this pandemic has really changed how we approach a lot of stuff in medicine. And as an oncologist, someone who treats patients with cancer, it is something I talk about with all of my patients. When someone has an active cancer, including a lung cancer, you are at increased risk of side effects from COVID. So the mortality rate with COVID goes up in patients who have any cancer, but especially lung cancer, because your lungs already aren't functioning at 100% capacity. So I do recommend that for my patients or people at increased risk of lung cancer, if you're at increased risk of lung cancer, it's because you're at increased risk of lung damage. And again, that's from smoking. So I recommend that everyone social distance and wear a mask, wash their hands, and try to avoid, groups of people, just because there is so much asymptomatic spread of the community. And those numbers are going up in Indiana. I think this was this week in Indiana, we had the highest 7-day average that we've had since March. So anyone with lung cancer at increased risk would also be at increased risk of COVID mortality. So I do recommend social distancing in those patients.
Okay, are all cancers lung cancers, or are all smokers cancers squamous cell?
So squamous cell cancer is so smoking does often cause squamous cell cancers, but no, not 100% of squamous cell cancers are caused from smoking. When we look at small cell cancers, it's thought that probably 99 to 100% of those cancers are caused by smoking.
Okay, and then what about other causes of lung cancer, such as asbestos and chemicals? Are those treated differently than when cancer is caused from smoking?
So that's a really good question. We do know that there's other types of inhalation and asbestos that can increase lung cancer. Those are not treated differently from lung cancers caused by smoking. Really, what determines how we treat a lung cancer is the size of the tumor, the type of lung cancer, so small cell or non-small cell, where in the lungs it's located. So those things really determine our treatment, not necessarily what caused the cancer.
Okay, we have, a few more questions. This is great. I've heard that lung cancer in young women is on the rise, or a growing trend. Is that something that you can talk about?
So we are seeing a slight increase in cancers in younger patients. Oftentimes it's twofold. It's either that, people have access to cigarettes at an earlier age, and so they have an increased damage to the lungs. The other thing is as we're learning more about genetic mutations, we are seeing some very rare mutations that are positive in patients, especially young women who've never smoked, who sometimes can have lung cancer. The other thing is there are other rare cancers that can present in the lungs themselves that may not necessarily be a lung cancer. So this is like a weird concept, because what cancer would it be? But sometimes there's cancers of the hormones or cancers of what we call germ cells, and those can present in the lungs, but they're not necessarily lung cancer.
Okay, and then pulmonary fibrosis and lung cancer. Can you talk about that?
Sure. So pulmonary fibrosis is basically increased scarring in the lung. So increased scarring and scar tissue. So while there's not a direct correlation that pulmonary fibrosis leads to lung cancer, there is evidence that there's some increased incidence of lung cancer in people who have pulmonary fibrosis. But that may also just be what caused both of those things. So it's more likely the things that cause the pulmonary fibrosis may also increase the risk of lung cancer. But unfortunately, there isn't a lot of studies about the correlation of pulmonary fibrosis and lung cancer itself.
Okay, and what about oral cancer pills? What are they and when are they given?
That's a great question. Oral cancer pills at this time are not a cure for lung cancers. So those are reserved for patients that we don't have options to cure them. So for early stage lung cancers, we offer surgery, chemotherapy, and radiation, or a combination of those three, to cure patients. When patients have lung cancer that's spread beyond the lung to the bones or the liver or to other places, and we run their lung cancer for these special tests for the 40 to 50 different gene panel, if they have a positive mutation, so a common one is called EGFR. About 25% of patients with lung cancer have an EGFR mutation. So if they have advanced disease, we can give them a pill that targets EGFR, and that's an oral pill. Unfortunately, where we're at with these oral pills is they can control the cancer for anywhere from 6 months to several years, but they aren't able to cure the cancer completely in most cases.
Okay, a couple more questions came in. How long can people live with lung cancer?
So if you had asked me this question 5 years ago, my answer would have been completely different than today. And part of that is because we are having increased advancements with advanced stage lung cancer. So for early stage lung cancers, we can expect most patients to live more than 5 years. About 60% of patients will live beyond 5 years. Now, as the cancer gets larger and the stage goes up, meaning that it's a more advanced cancer, that goes down. As of 2012, the average patient with stage 4 or advanced lung cancer, meaning outside of the lung to another organ, only about 1 in 20 patients lived 5 years. That is kind of changing right now because we're seeing an increase in oral pills for people, immunotherapy, different options. So that number is probably going up. And if you ask me in 5 more years, that would probably go up even further. So I would probably estimate, about 10% of patients probably live 5 years or so that have advanced disease. And again, this is a place that we're working on, and that's changing quite a bit. Every month, the guidelines change for our advanced stage cancers and the best options for patients. But at this time, we still don't have cures for our stage 4 patients. So while the 5-year survival is going up, it's definitely not what it is for patients that have early disease that we can cut out or radiate or give chemotherapy to.
Okay, thank you. How does immunotherapy work?
All right, these are really good questions, and these are questions I get asked a lot in clinic. So there's about 5 years ago, we started thinking about the immune system, and everyone's immune system is different. And there was a lot of really smart people in the US and Japan that thought about, well, what if cancer is hiding from the immune system? So there were a lot of studies done, and we basically found that part of the immune system, like the reason cancer can grow is because some people's immune systems are blindfolded. So basically what some cancers do is they put a blindfold on the immune system. And so the immune system doesn't know the cancer's there, and the cancer will keep growing. Now, our immune system fights infections, but it also actually helps us with any sort of atypia in our body. So what immunotherapy does is it's basically a switch. It goes in and it takes off the blindfold off your own immune system. So your own immune system wakes up, it can open its eyes, and it can target the cancer and help basically kill the cancer. So immunotherapy is basically turning on your own immune system to target the cancer.
Thank you. There's another question. I have a friend who has 2 types of lung cancers at once, 1 type in each lung. How does that happen, and is that common?
So it's not common, but it definitely happens. So in the last 6 years of my practice, I've probably seen that maybe like once or twice a year, we'll see patients with 2 different cancers in 2 lungs. And the reason we know they're 2 different cancers is because each one will be different. So we talked about the histologies or the makeup of the lung cancer. So in the right lobe, they may have a squamous cell cancer. In the left lobe, it may be an adenocarcinoma. So this can happen, again, because most of the causes of lung cancer are smoking. So we know that patients with lung cancer, who are smokers, if they've had 1 lung cancer, their risk over their lifetime of having a second cancer is about 5%. For patients that have small cell lung cancer, if they have a cancer, their lifetime risk of a second lung cancer is about 20%. So because of smoking, it increases the risk of not only one lung cancer, but it also increases the risk of 2 lung cancers. And sometimes people can present with 2 different lung cancers at the same time.
Okay, thank you. Someone here says they're trying to quit smoking and they want to know about any tobacco cessation programs and if that is helpful and successful for stopping smoking.
So one of the things I try to talk about a lot in my clinic with my patients is quitting smoking. It can be very hard to quit smoking. It takes the average person about 14 times to try before they can quit. Nicotine is addicting and it can be something that people depend on psychologically. The other thing is under times of stress, which I would argue that 2020 is a very stressful time for all of us, it is that much harder to quit smoking. So a lot of times I'll see patients when they have cancer and we'll talk about quitting, and it can be difficult because it's a stressful time. There are quite a few different products out there that can help people quit smoking. So nicotine patches are a way for you to get nicotine replacement that's not through the cigarette. And eventually the goal is to wean off the cigarettes and wean off the nicotine patches themselves. It takes about 28 days to be nicotine-free to technically quit smoking. But of course, there's also a psychological addiction. So some people can go back even years after they've quit smoking. What my favorite thing to do in clinic is to talk to patients about pills that can help them quit smoking. So the one that I prescribe to a lot of my patients is called Chantix. There are some side effects of Chantix, but people are about 10 times more likely to quit smoking on Chantix. So it's a pill you take every day, and after a week of taking it, it builds up in your system and you quit smoking the 8th day you're taking it. So you basically take it for a week, and then on the 8th day, you quit smoking. And you follow up with a physician about once a month or a smoking clinic once a month to kind of see how your progress is. I would say most of my patients who try Chantix, who really are motivated to quit, are more successful to doing so. Some of my patients have been smoking maybe 2 or 3 packs of cigarettes a day for years, and they can get down to 1 pack and then over time half a pack, and then eventually can quit smoking. If you're interested in quitting smoking, call your primary care doctor and talk to them about a plan. We do have smoking cessation clinics. We can work on this together. I try with all of my patients to work on smoking cessation because it is really important. But one thing you have to remember is that it's not easy to do. It does take some time, and it can get really frustrating trying to quit because people can relapse, they can smoke again. So it's just important to remember that it does take several tries to eventually quit, but it's always more successful if you try either a nicotine patch or a pill to help, and if you talk with a provider who can kind of coach you along the way.
Thank you. And we do have an Aspire tobacco cessation program located across all of our Franciscan hospitals, and so we'll send that information to all the attendees as well. We do have another question on a risk. If you're exposed to secondhand smoking and other environmental or workplace risk factors like radon, does that increase your risk for lung cancer?
So the short answer is yes. There is a slight increased risk from other exposures such as radon and secondhand smoking. It's hard to quantify those amounts. Like I can't give you an exact number, but there is thought to be an increased risk from inhalation of smoke or from radon exposure.
Is there a diet that can help lower your risk for lung cancer?
Unfortunately, at this time, there's no dietary guidelines that we found that helps reduce the risk of lung cancer. The main thing is a smoking cessation, but at least as of now, I know that diet is definitely important in general for everyone's health, but we really haven't seen a link with lung cancer and certain diets.
Okay, and we just have time for just a few more questions. So a few more came through. My brother had cancer in the lining of his lung. How is that different than a lung tumor? Is that type of lung cancer treated differently?
So it sounds like your brother probably had a cancer of the pleura, which we call a mesothelioma. So the lining of the lung itself is called the pleura, and so that is treated differently. It's treated as a mesothelioma, so that gets slightly different treatments than lung cancer.
Okay. And is having too good of an immune system, can that hurt you?
So at this point, there isn't any data that having too good of an immune system would cause lung cancer or or would hurt you. There are instances like when your immune system is too revved up, you can get autoimmune diseases. So people that have lupus or have thyroid issues, sometimes it's because their immune system is in overdrive. But in terms of lung cancer, if your immune system is hyped up, it shouldn't affect a cancer.
Okay, and the last question here is, I don't know if I'm going to say this right, cyclophorex. Is that a cancer?
I think it might be kylo, and that's
yes.
Sometimes when there's lymph fluid that's in the lungs. That is not a cancer. But oftentimes we have to look at what caused the kylo, so the doctors will investigate a little bit further. But just having that fluid in your lungs is not associated or equivalent to a cancer.
Okay, wonderful. Well, to conclude the evening, Dr. Mangar, are there just a few other key takeaways that you want to reiterate to our audience to close out our webinar?
So first, I want to thank everyone for tuning in. I really appreciate it. I'm so passionate about smoking cessation and about lung cancer because it really is something that is still affecting Americans more than any other cancer and more than other cancers combined. Unfortunately, most of our lung cancers are found when they're at advanced stage, so they're not cancers that we can cure. And so the way we combat this is really twofold. One is it's so important to quit smoking, even if, it's not for lung cancer. Quitting smoking is the one way to increase your lifespan no matter what. So that's an important thing. So we decrease the amount of lung cancers in our world. But the second thing is that if you are a smoker, if you've had a heavy smoking history, it's important to get a low dose screening CT every year because again, that helps save more lives than colonoscopies and breast and mammograms combined. So those are really the take homes. One of the unfortunate things is that only 1 in 8 people who qualifies for a CT scan for lung cancer screening actually gets it. So if it could be 8 out of 8, I can only imagine how many lives we could save screening people early.
Thank you so much, Dr. Mangar, and for putting you on the spot at the end with our videos not working. And I apologize to our attendees. We will make sure you get that links to the videos and to all the other great information and handouts and follow-up emails. And thank you again for attending this Free to Breathe Understanding Lung Cancer Prevention, Detection, and Treatment. We know your time is valuable, and we definitely appreciate that you prioritize your health today. Have a blessed evening. Thank you.